Gracias, ¿qué tal?
Bien, gracias.
Muy Maria.
I have 10:01, Jamila. Do we still have folks in the waiting room, or is everybody admitted?
Everyone is admitted.
Okay. Sorry, did somebody say something?
It is very possible my YouTube versus my Zoom started talking to each other.
Oh.
I was checking our live stream. We are live.
Fantastic. Welcome everyone who's joining us on the live stream today as well. Thank you to all of those folks who are doing the captioning for us, both in Spanish and in English. We so appreciate all that you're doing to keep this really accessible for folks. So thank you folks for doing that. I have 10:01 and I know we have a lot to cover this morning. I'm going to ask that Jamila go ahead and continue to let folks in to the meeting. So welcome everyone. It's so good to be with all of you this morning as we finalize our recommendations to OHA and the governor's office. I hope that you all have your tea, coffee, and water as we start this morning. I know that, you know, as we move through the next couple of hours with intention, I really want to make mention that we continue to offer each other grace, patience, and understanding through this process. I would encourage folks to please keep comments and questions brief, knowing that we want to be mindful of sharing the space with one another. And also, I'm going to ask that when you have a question or comment, that you use the raise your hand function. I will be able to see that today as the co-host capabilities. And so Jamila will also be helping me to moderate the chat function. So for those of you who want to use that function, please do so. We'll try to go back and forth, kind of moderating that as well today. We also need to take an accommodations break at 11 o'clock. We'll do a 5-minute break today. So please keep that in mind. And again, my name's New. I'm really happy to be here with you. I go by she, her pronouns. If you want to go ahead and place your pronouns in the chat, that's another way we'll be able to take attendance today as well. Thank you again for being here. Some things that OHA staff and as we work through today, things to keep in mind. We want the VAC to really be thinking about how we want to provide language around the intent of the recommendations. So how is the VAC using the data of who is most impacted? And is that the place where we want to focus on, focus there, right? Also, it's really important and helpful to, by the end of the meeting, that with sequencing, how will we sequence the remaining groups and how will they fall in order? So last week we did start the conversation around clarifying underlying health conditions with the focus on equity. So thinking about that, what's next, right? And I know we haven't finalized any of that or agreed upon any of that yet. And so just kind of keeping all of those priority populations in mind, what's next, right? I'll really work hard to kind of keep us moving along to push us to make decisions today as well. And then really also thinking about the need for some more clarifying and more discussion and definitions around critical workforce or frontline workers. So who's included in that? So part of that is us really the VAC determining who's included in the definition for frontline workers. So for example, do we start with food and agriculture folks, right? So I also know that today we do have a short presentation from Shimi, and then I know that Rachel has a few words for us as well to kind of help ground us again in thinking about some of the definitions and the legalities on some of the pieces that we are working on. So with that, I'm going to pause for a second to see if folks had any quick questions about the process today. I do want to make mention that we won't be wrapping up, we will be wrapping up recommendations today, but for a closure on this group, we're going to send you an email kind of asking and suggesting how we do the wrap up and the closure of this group. But that won't happen today because we really wanted to focus on giving folks the full time to do this and not spend too much time wrapping up. I'm going to go with Lauren and then Leslie. Both their hands are raised. So, excuse me, Lori and then Leslie. Please, Lori.
Thank you. So good morning, everyone. I just want us, as we proceed today, to be mindful of the fact that we're prioritizing hundreds of thousands of people, which far outstrips the supply of vaccine. And so I just think it's important to be mindful of the fact that if we prioritize certain groups that exceed that demand, it could create negativity or additional mistrust in the sense that they were prioritized but may not have access. So I think we just have to keep that in mind as we move forward.
Thank you, Lori. Thank you. Leslie?
Thank you, Nu. I just had a clarifying question. Are we being asked today to say who fits in phase 1B, or are we being asked to create a sequence of in 1B, this group goes, and then this group, and then this group? I think that will help me at least understand what our task is today. That would be helpful. Thank you.
Yes, absolutely. And my understanding, thank you for that question, Leslie. And my understanding, if you were to go to the OHA website right now, there's already a chart, right, that was posted on January 22nd that kind of lists that group of folks that includes educators, people 65 and over, and then kind of within that groups of folks, people 80 and older, 75 and older as different groups. My understanding is this group here will, within the groups that we had, the priority groups that we had put forward a couple of weeks ago, we will be prioritizing that group as far as sequencing. Rachel, do you want to add to that as far as where folks are landing today?
Yeah, I think you got that right. So we know that there are some folks who in 1B are moving forward now, like you talked about education, childcare, early learning settings, as well as those 65 and older. And I think it's been great to hear the conversations in the VAC thus far, who have included a variety of other groups that you all want to see in 1B. So to the first part of your question, Leslie, I feel like that who's potentially in, has been identified in adults in custody and those with underlying health conditions, and making sure we get to seniors under 65 in congregate care, multi-generational households, and all of that. And then what's most helpful at this time is to continue the conversation of how we move through those groups, to Lori's point, knowing that we will not have enough vaccine, at least not what we know at this point, to have the entire population move forward at the same time. So how do we want to think about sequencing those? Given, and I think that where we could leave off is last time the group really talked about the importance of underlying health conditions. And there's also been conversations, and people have brought forward, critical workers. So understanding where you all want to see sequencing or prioritization, moving down that list would be extremely helpful. And ultimately, it would be a great problem to have if we have many more vaccines and we don't have to sequence in that order. But at least for now, knowing how we plan step by step is most helpful.
And then Muriel, I see your hand raised. I'll go ahead and take your question.
Yeah, just a quick one. I think I just wanted to say, as we think of this too, I think it's important to think about, for many of the smaller counties in Oregon, having some concurrent groups. I know it's harder in the larger counties, but it's hard for us when the group is really small and then we're supposed to wait. that does not make our communities very happy. So how we can also try to balance this between different size counties, I think is really important.
Great, thank you so much. And it looks like there's lots of action going on in the chat already. Xenia, yes, Jamila, please.
I apologize for cutting in. I'd really like to, before we get started, I'd really like to acknowledge the request that this group made, that before we get into this business, we do a land acknowledgement. Kristen, would you be willing to pull that up?
Thank you, Jamila. Thank you, Jamila, for pausing me. Thank you.
I would like
that.
to honor the urgency of this conversation while holding to this acknowledgement and this holding space for our contemporary and historical context of this work.
Great. Thank you so much, Jamila. I so appreciate you stopping me. Thank you.
Tribal land acknowledgement. And as I read this, I'd like to acknowledge that this was written from a Portland specific perspective, and our organization and team are working to update this and broaden it for conversations like this, where we're really looking and talking to all Oregonians. So we acknowledge that what we now call Portland, Oregon, and Multnomah County are the ancestral lands of the Multnomah, Wasco, Cathlamet, Clackamas, Cowlitz bands of Chinook, Tualatin, Kalupa, Malawa, and many other tribes who made their homes along the Columbia and Willamette rivers. We are here because this land was occupied and its traditional people were displaced by colonists and settlers. As settlers and or guests, we recognize the strong and diverse Native communities in our region today, from tribes both local and distant, and offer respect and gratitude for their stewardship of these lands throughout the generations. I apologize for my misspeak. Would you go to the next slide? Additionally, we'd like to acknowledge some historical context. We acknowledge the generational trauma and mistrust towards government and healthcare systems. The experience of harm and fear grounded in settler colonialism, systemic racism, and ableism cannot be discounted. Governmental public health must work to ensure access to services, care, safe vaccination pathways, and transparency. Thank you.
Thank you again, Jamila and team, for slowing us down and just, again, giving us a chance to breathe and root us into the work that we're doing. That is, so thank you. Thank you for stopping me. I believe I had a hand raised, and then I'm sure I have several hands raised at this point. Zhenya, I know that you had your hand raised. Did you want to make a comment or question?
A question. Is it within VAC's purview to potentially recommend that counties have more flexibility depending on their demographics of how to prioritize vaccinations within the greater group and effectively honor the principles that are formulated, but give counties more on the ground flexibility based on the earlier comment and several other comments that I've heard?
Yeah, I believe, Rachel, is that something that you can comment to?
Sure. So I think there's a number of ways to get at working with counties towards equity. Right now, what happens is that sometimes there are allocations of vaccines to hospital systems within counties. Some counties are working directly with their hospital systems and have a variety of different agreements there. There's also allocations that are made directly to counties, and in those allocations, there's flexibility in terms of how counties want to be working with their communities. I think additionally, we through the guidance documents and through how OHA communicates about its values and expectations about vaccine, that's where we really communicate our expectations around equity. But ultimately, our local public health partners, we know that they know their communities best, and we're hoping that, you know, as the work and the partnerships evolve with community-based organizations, that those equity principles and priorities are put into place. So yes, there is a variety of different ways. I think there's a both and of, we want to have some clear standards, guidance, and expectations across the state. And Zhenya, thank you for that comment around having flexibility so that counties know how best to do that in their communities and how best to make sure that they're working with those folks who may be overlooked.
Great, thank you. Muse, you have your hand raised.
Yeah, I'm just raising my hand as far as handing over directly to the counties without OHA leaving there. I think that is something I would love to have OHA continue with, having their hands and their eyes as this is being processed through the counties. I think that would be much more equitable and also make sure the handover is not just free for all. Thank you.
Thank you, Muse. Safina, you have your hand raised.
Yeah, instead of just writing agree in the chat, I wanted to wholeheartedly agree. And I think where the VAC can really offer is that, you know, more broad advisement on larger populations that are most disproportionately affected at the state level, which ultimately is going to be a lot of people. But then if the VAC does advise language on in ways to talk about what the principles are that OHA wants counties to utilize in doing sub-prioritization or community-informed, equity-informed prioritization within their counties that are, again, informed by the communities. I think it will be most effective because ultimately the way that those communities are going to receive the vaccines are going to be more locally and community informed. And so I think that there could be like a tiered process and an acknowledgement that the groups that are prioritized, it will take months for them to, at this rate in terms of vaccine allocation. The reality is it is going to take months and we're not going to be able to complete one group and then another. There's going to have to be multiple parallel processes. So allowing the, you know, creating some guidance, the verbiage we can help with by the VAC, but really taking the concepts of having it be more locally led. The data that we saw does show a big difference in each county based on the proportions of communities affected. And I think it's just really, really important to move in that direction.
Thank you, Safina. There was a lot of information that was shared over the last 24 hours. And so I know that folks have been going through a lot of that information. So thank you for that. Marin, I see that you have your hand raised.
You know,
Please.
just in terms of recommendations, can we start the PowerPoint and the lecture first and we can get into a discussion? Because I want to hear from the information that you shared with a PowerPoint.
Sure. And I think that's a nice segue. So next we'll have Shimmy share some information about a couple of the different populations that we haven't got a chance to get more information about. So if we can go ahead and pull up the slides and presentation for that piece.
Hi, everyone. Sorry, I'm going to leave my video off. It's a lot faster to scroll through the slides I'm already seeing. But I wanted to present some data that was requested by you all via email over the last week regarding some better numbers and estimates on, the populations that we're actually looking at today. Can you go back to the previous slide, Kristen? What was that? Was it just, okay, cool, perfect. Next slide. So just a little bit of context on adults in custody in Oregon. You must have received the letter of clarification that we sent that a small number of adults in custody have already been vaccinated, but the majority of this population does remain waiting to be vaccinated. To give some context as to the urgency of vaccination in this population, confirmed adults in custody positive cases since the start of the pandemic has been over 3,000 cases. And of that, 2,697 have recovered. Out of the deaths, we have a total of 39 at the time of this writing. Staff have also been disproportionately affected at 782 positive staff, and recovered staff at only 677. And currently, at the time of this writing, all but 2 facilities are currently experiencing an outbreak as well. And the reason is the inability to appropriately cohort and distance between adults in custody who are and aren't experiencing COVID-19 symptoms. Next slide. I know some of you requested data regarding race and ethnicity data in essential workforce sectors and industries. We actually don't have Oregon data at that granular level, but we would like to present this study that was shared to us by Dr. Qureshi about the summary of results from a California study looking on deaths in essential work sectors. So in California, and the time frame that they used was between May and October of 2020, all during the pandemic. They noticed that there were, March and October 2020. Excess deaths of over 10,000 people in California, ages 18 to 65 years of age. And of these, there were relatively large numbers of deaths among the facility sector, which accounts for chemical, energy, and water sectors. Of 1,681 of these excess deaths, and transportation and logistics, which includes transportation, both public and private sector, as well as logistics, meaning movement of goods and supplies across geographies. 1,542 specifically of these deaths were in that sector. Next slide. Mortality was also increased during the pandemic, and specifically the breakdown was the highest of these cases were among food and agriculture workers, 28% among transportation and logistics, 27% among facilities workers, and 23% among manufacturing workers. Manufacturing meaning factories and other facilities, including food processing, I believe. Oh, actually, sorry, no, food processing is in food and agriculture. Next slide.
And Shimi, would you share the definition of facilities if you didn't already?
Yeah, it was on the first slide. So facilities accounts for chemical, energy, and water sectors. In this study specifically, they looked at race and ethnicity among California workers who are disproportionately affected in these essential sectors, and specifically Latina, Latinx Californians experienced a 36% increase in mortality, of which 59% were specifically in food and agriculture workers. Black Californians experienced a 28% increase in mortality, of which 36% were in Black retail workers. And these are just the highest proportions of that increased mortality. And this is what they actually presented in the paper. Asian and Pacific Islander were grouped together, and the data was actually collected from death certificates, so it's not as granular as some of the other survey data and form fields that we do have. It is a free text field, so Asian was grouped together in one whole, which would include Pacific Islander, and Californians experienced an 18% increase total. And of this, 40% were actually in healthcare workers. And the white working age Californians had an increased mortality of 6%, of which 16% were again in food and agriculture. Next slide. We have some additional data that we were able to pull in Oregon. Jamila, I think this might be in the form of a Word document, or Kara might know the outbreak data in Oregon since the start of the pandemic by enumeration of facility type.
I'm working to pull this up.
Okay. Thank you, Kristen.
So we had one of our epidemiologists pull the data in terms of Oregon COVID-19 outbreaks by location. This includes all data from March 2020 up to, I think this data was pulled 2 days ago. So as you can see, we've highlighted the ones where we have large numbers as well as populations that actually haven't been identified for vaccination yet. We've kind of left out K through 12 schools as well as child daycare settings because they have been prioritized in the governor's order. So we do see a sort of disproportionate number of cases in farm and dairy plants. This includes nurseries, seed farms, produce, meat, and dairy. Food processing is similarly elevated, and this includes frozen foods, meat processing, bakeries, and beverages. Factory and manufacturing, including tech, I think, is that technology? I'm not sure what tech means. Timber, warehouses, woodworking, and metalwork. And congregate care settings have already been prioritized, except for the few that haven't been, which includes adults under age 65. So they had 2.8% of all outbreaks in various sectors, construction and subcontracting, grocery stores. Sorry, the chat keeps interfering with my view. 1 second. Construction subcontracting was 2.5%, and this includes plumbers, roofers, and general contractors working on site. Grocery stores were 2%. Religious facilities formed 1.9%, and retirement and independent living facilities formed 1.9% as well.
Shimi, this is new. Can you speak a little bit to how using California data and Oregon data, how that
would work?
Yeah, how does that work? There was some questions about that in the chat.
Yeah, so California data is not going to be wholly representative of Oregon data. California is only 37% white demographically, so their workforces look very different from Oregon. In Oregon, unfortunately, we weren't able to correlate the race with our various sectors, but there are some sectors, especially in food and agriculture, that are predominantly occupied by people of Latino descent. But beyond that, I actually don't have any data that I can present as to the ethnic makeup of a lot of these sectors, but these are just kind of data, at least that we're able to present, that shows high percentage of outbreaks. Does anyone have any questions before we move on to Rachel's slides?
Jimmy, I have a question. This is Kalani. Is this number of cases, when you say outbreak, is this number of cases in it at each facility? And then the percent, is that percent of total?
Yeah.
Okay, thank you.
This is Dean. Just to clarify, it is actually number of outbreaks.
Oh, it is
we
a
don't
number.
have the number of people behind them. Sorry.
So there were 986 outbreaks in nursing homes affecting a larger number of people.
Correct. Unfortunately, in the timeline, we couldn't pull the additional data as well, so I apologize for that.
Okay. No, that's helpful. Thanks.
I see George's hand.
I'll just point out, I did send a spreadsheet that we had shared last week with OHA. I don't know that you had time to look at it, but it does include the enumeration of cases by county and by outbreak type. I sent that just maybe an hour ago or so. And then I have a question. So are we going to talk about the implementation draft table? Because the first table has these 3 really huge cells, the BIPOC, adults 16 to 64, and frontline workers. Has anybody cross-tabulated that so we have an idea of the overlapping cells? Because I think that's probably how we'd have to prioritize, since this is a total of half the state if you look at the total of these 3.
Yeah, I don't know that we've tabulated any of that, George. I think that is a good segue into looking at not only that piece that we sent to the VAC, but also giving Rachel an opportunity to talk about the use of BIPOC as moving that forward as a population group within the VAC's recommendation, and what does that look like with the legalities of that? Because I know there's been discussion about that as well. So as we pull up that piece, perhaps let's pull up Rachel's slides. Are you using slides, Rachel?
So yeah, I sent a couple of slides over. I'm not sure if folks have that. You might have gotten them from Kara.
Yes, Kristen, it's in the folder, but I can pull it up if needed. Okay.
Thank you, folks.
All right, so huge caveat, I'm clearly not an attorney. This is not legal advice. Whatever other caveats I need to say that I didn't say, please take those into consideration. But ultimately, as we promised, we went back with the recommendations and the conversation that VAC has made thus far. And what I really heard from folks over and over again is that based on the data, we want to prioritize those folks who have the greatest risk. And those risks come in a number of ways. Those may be risks for getting COVID. They may be risks for exposure to places that are experiencing outbreaks. Those could be risks of if people do get COVID, that there's more severe illness and or that there's disproportionate deaths. So ultimately, from a sense, that's where we need to land. And what we do know is that we're not able, and I don't feel like this was the intent of the conversation that you all had either, we're not able to prioritize services or make decisions based on services solely on somebody's race or ethnicity. So once again, we're looking at this in a lot broader factors, and I know that the conversations that folks have had have really been based on that data. But to clarify, we're not able to make decisions on resources solely based on somebody's race or ethnicity. I think about Dr. Judelau, who I've heard talk about this, that the reason we measure race and ethnicity is not based on the construct, which is a social construct, it's made up, but it's really to understand the experience that people have with racism. So in this slide, we're really wanting to connect the dots between our goal of reducing health inequities and really making those connections of risks and structural racism. So I'm actually gonna read this slide, which I don't always read slides, but our goal then is to prioritize people who experience the kinds of risks that lead to adverse health outcomes. But we know that structural racism has created systems and conditions, policies and practices that place Black, Indigenous, people of color, tribal communities, we can add refugee and immigrant communities, into the kinds of jobs that put people at a greater risk, as we've seen in the data, into the kinds of housing that put people at a greater risk, into the sort of health problems that put people at a higher risk, and creates barriers to accessible and adequate and appropriate healthcare and other preventative services. We've also seen that COVID-19 has exploited those injustices and the kinds of vulnerabilities that racism creates. So next slide, please. So the way that we're able to look at how we distribute vaccine, once again, focused on those who have the greatest chance of having adverse risk, is here's some conditions. So once again, based on data, we're prioritizing individuals and or groups that experience the highest COVID-19 rates, highest risk of exposure, highest risk or actually the risk and the severe illness that we've seen in the data, unfortunately, and deaths. And these may include, but are not limited to, those who work in occupations that put them at an increased risk, those who are in living situations that put them at an increased risk for any of the aforementioned issues, those who are from groups with current or historical health inequities, that could be with COVID-19, or for example, other underlying health conditions that put folks at an increased risk of severe illness or death. those with underlying health conditions that put them at an increased risk for more severe disease or death, and those who live in areas with overlapping increased risk or decreased access to health services. So this is really a framework where we can, no matter who we're looking at, no matter what occupation, no matter what living situation, where we can within that really analyze how Black, Indigenous, people of color are impacted within any of these risks. There are also categories that are not solely based on risk, but we know from studying health inequities and the way that structural racism works that Black, Indigenous, and people of color, unfortunately, are disproportionately represented in a number of these risks.
Thanks, Rachel. I'm going to take Dr. Doldalau, Dr. Gonzalez next, and then Marin next. After that, those three folks are up. And then after that, I'd like to take a quick pause to check in to see if we can't move towards that chart that was sent out. And so looking at the priority groups based on what Rachel has given us and then the conversations that we've had. So that's kind of this next piece. So Dr. Doldalau, Dr. G, and then Marin, please.
I just had a quick question about the going back to the outbreaks, and just wanted to know if that enumeration included all outbreaks or just those with 5 or more people. I remember that OAJ was not reporting smaller outbreaks on their website.
Dean, do you happen to know the threshold for reporting outside of the child daycare? Because I think child daycare is only 2 cases, but then I don't know what the thresholds are for the other sectors.
Yeah, I believe that these are all pulled on the 5 or more cases in a workplace of 30 or more. That's when the outbreaks are created, and we have to go based on that to pull the data. So that's what our epidemiologist did.
Okay, thank you.
You're welcome.
Kelly, you're up next.
Thanks. Okay, I just want to provide three points to the last few slides. The first is kind of expanding, I think expanding our idea of the impacts of racism, not just limiting it to a function of employment. That racism is also playing out within the context of our public health systems and our medical systems. I'd like to see an acknowledgement of that. Also that we have, that racism impacts lack of access to resources such as employment and education. And then finally, racism plays out even in our data, as we saw with, when data systems are not equipped to capture Native people, as was shown in the California data. We're not, when we are not included in the data, then our needs and are not understood and are, we're not involved in the solutions.
Thank you, Kelly. Marin?
Thank you. Rachel, can you talk about or expand about when it comes to other states facing legal issues in terms of choosing race or ethnicity as a point of prioritization? Are they using social vulnerability indexes or disadvantage indexes in a way to kind of address those issues with these vulnerable populations? Or can you talk about anything about that in terms of that social index and the vulnerability or disadvantage index and how that can be used? Because I know other states are facing legal or have faced or maybe scared of legal challenges. So I guess, in terms of strategy for us here locally, what do we do? And so I want to expand, if you can expand more on the social vulnerability index, if that can be used in a way for us to capture these vulnerable populations.
Yeah, thank you for that question. So what we have seen is that the social vulnerability index can be used to get at vulnerable populations because it has the ability to layer on many things and really look at not just an individual, but a group or a community specific approach. That said, I know we could have hours and hours of conversation about the limits of the social vulnerability index and the limits of the data that it's using as well. But I think where it is useful, there's a couple of areas that to me I think are particularly useful. One is in getting at multi-generational households. It just allows us to take a broader view than just the individual. So whereby we may use other indicators, let's just say a workplace, we could identify where individuals work, but they may be working in one setting and then ultimately going home in another setting. So I think when I think about it in terms of its usefulness of VAC recommendations, that's really one area that you all pulled out of, like, what about the household setting that I think the social vulnerability index could really help us get to. And then the other is just it overlaps. So to Kelly's point, or Dr. Gonzalez, sorry's point about the multiple ways that racism impacts, with a social vulnerability index, you could look at the way that racism has impacted resources, what that does for education. You can look at obviously demographics as well as occupation, the housing. So there's just a variety of different ways that the social vulnerability index helps us take a broader view of the outcomes and looks at neighborhoods that have been under-resourced or overburdened with society, unfairly overburdened with society's burdens as a product of structural racism and other policy and investment decisions.
Because I guess I'm concerned into the legal challenges. Let's say if we pick, BIPOC by name, and how would that go with the courts and delay some of the process that we're working on? And so, because a lot of the BIPOC people fall into these categories you mentioned, so I think that would work in terms of addressing some of those concerns. But thank you.
I do want to acknowledge that there was a question in the chat specifically. Can you read Deborah's question, Jamila? I lost it in my...
Me too.
Yeah.
Is anyone here getting information from IHS, which is Indian Health Services? I look to Rachel or Dean.
Dean, would you be able to speak to the extent to which our data is inclusive of what we know from IHS, either in vaccines or other epidemiology? I'd have to do some more digging to be able to answer that question unless Dean has the answer.
Right. I'm not sure in this, in the data on COVID right now. We do work to try and match our data ongoing, like from data systems like Alert to IHS, to see if we're identifying folks that we did not have the racial ethnic data on that we can identify as tribal affiliated here in Oregon, but I don't believe we've done that with the COVID data to date. I will have to get back to you.
Thank you. And per an agreement with New, I'll read Zenya's question that's typed out, unless you'd like to read it.
No, go ahead.
Is it going to be viable to distribute vaccines based on geography? For example, if the social vulnerability index suggests a pocket that needs to be prioritized, do people living in that neighborhood need to go to a central place and prove they live there? Or will the vaccines come to them, such as through a turn-based vaccination?
Church is what was supposed to say, as an example.
Oh, okay.
Okay, so I think there's a number of ways, and this really gets to the operationalization of any of the vaccines and the policy decisions and recommendations that you all are making. So just a side step before I answer that is that we will take the recommendations from today, do more operational analysis, be working with the governor's office in determining how to roll this out. And I think, you give a really good example, Jenya. So we could use a geography-based system in a variety of different ways to look at vaccine allocation. And, ultimately the advantage of that and how it would work best is to be able to have resources that are closer to people's homes or neighborhoods or counties or what have you. Right now, I just want to acknowledge that we have a lot of mass vaccination sites and people are traveling long ways. Our intention moving throughout and as we get more vaccine is to distribute more broadly so that vaccine is closer to where people are, easier to where they can get to. In regards to specific examples like faith-based organizations or community-based organizations, one of the things to keep in mind when we think about how do you operationally carry this out is right now that the vaccines that we're working with are pretty finicky in terms of their storage and moving and some of those. That said, we know that there are also other vaccines that are under development that don't have the same cold storage requirements should they be approved and or one dose. And so I think these sorts of strategies are really good for us to be thinking about, hearing from you all, and then planning towards, even if we're not able to implement them immediately, those are things we want to be able to work towards. And so to sum that up, yes, having a neighborhood based or a census tract based social vulnerability index strategy does allow us to do planning with community, and I think ultimately think about ways to get vaccines closer to where people need them.
Thank you, Rachel. I know that there's some additional comments in the chat. I also see that Muse, you have your hand raised. I'm going to call on you next. After Muse gets an opportunity to jump in here, I'd like us to shift gears slightly and look at the priority populations that we have come up with, and then start really thinking about prioritizing and sequencing with that. So Muse, please.
Oh, thank you very much for the opportunity to speak. Number one is one thing I want to remind people. It's one thing is you need to know the difference between equality and equity. And if we don't do this work equitably, I think we're going to miss a big point. Another thing I also want to repeat again is the fact that it has to be community CBOs being part of this, the fact that they have the trust of the community. You can bring any kind of stations anywhere you want to, but if they don't trust it, they will not go there. The same thing we do that. We get food from Sunshine Division to bring to our office to distribute to the community. The same boxes, they wouldn't get directly from them. So I want to make sure that's in mind. And I want to make sure OHA had oversight when they're distributing this to the counties and any other entities. So that's 2 points I want to make. Thank you.
Thank you so much, Muse. And I know that in Tuesday's presentation, we really had a good sense of some of the work that's being done in community with OHA. And so I know it's the intention of OHA staff and colleagues to continue this work with all of you in future, not just ending today or at the sunset of the VAC, but in the future that you continue to have these conversations, knowing that that's part of how we operationalize the intent of what the VAC wants to do. So with that, if I could ask, we pull up the chart of priority populations so that we can all, we've had some really good, robust discussions, but I want us to kind of keep moving forward. And I see the comments in the chat, and thank you for your patience as we kind of move forward with this. So is there a way to also see the page 2? If possible. Thank you, Kristen. So I don't want to lose sight of those groups down there as well, right? Because it's easy just because it's off that particular page, but the groups, thank you. The ones that we're looking at are BIPOC adults 16 to 64 with underlying health conditions. We still need to define what we mean, the VAC means by frontline workers. And then adults and youth in custody, and then multi-generational households, and then people living in low income and congregate senior housing. I know that that was also briefly discussed on Tuesday as well. I see a hand raised. Marin?
Yeah, I guess the question that I have is basically to my colleagues is regarding the list is in terms of the potential legal challenge. Do we use BIPOC or not, or a different word? That's I think a discussion that I want to have with our colleagues to see, risking whatever might come in terms of legal issues. I think we should talk about that.
Okay. Thank you. I want to acknowledge that Sandy also had a question in the chat. She's been waiting patiently. I'll go with Sandy, then Kalani, and then Sean.
Great. What I have asked is, we talk about doing this outreach as if it's, a long ways out, but I am really curious. I mean, what are we doing with the seniors who are going to start being vaccinated next week to make sure that we are reaching, BIPOC seniors, low-income seniors, people who can't get to these mass vaccination sites? I mean, these groups aren't monolithic, so we should be knowing how we're doing that now, and that will maybe inform what we do in the future. I don't think you can do it with, expecting seniors to show up at the Salem Fairgrounds or the convention center.
Thank you, Sandy. Kalani, then Sean.
I hear what people are saying about implementation, but I really feel like implementation depends a lot on the sequencing. Obviously, they go hand in hand, but I think today we have a specific task, and that is to get the sequencing done. And so I hope that we can do the best we can, recognizing that there are a number of implementation challenges that each of us are going to have to work with the state on. And then I would just like to make sure that we address Marin's comment about how are we going to address with BIPOC communities? Are we just removing them entirely from this table? And that's an important discussion we need to have. Thanks.
Thank you. I'm going to go with Sean. Leanne, I know you want to jump in here, and then Maria. And then let's get back to the discussion piece about how do we address the BIPOC piece that we've heard so much about this morning too. Sean?
Yeah, and thank you. And I think my comment actually speaks to both rather directly. And I share the same concerns that Marin has expressed and others about calling out BIPOC as an aggregate whole, and whether that will actually ultimately bog down the progress that we want to make. I think when Rachel's slides were up, I think it was slide number 2, that she had a list. It was entitled "Using Data to Lead with Equity" was the slide. Mm-hmm. And it broke out in very clear terms, essentially the same list that we're looking at right now, written a little bit differently. And it looked to me like if we were to work right off of that list of slide 2, but add some defining parameters to each of the points on there, we'd be making a lot of progress toward addressing the equity issues, but there would be definition around it that fit within, the workplace, the specific underlying conditions, frontline workers, youth in custody, et cetera. And that might be a place we could start working from. And then I also agree with the last comment on, operationalization is simply going to have to happen after we get to the sequencing, in my view.
Okay, thank you, Sean. I'm going to go with Leanne, Maria, and then Zhenya. I see you as well. And then let's, again, going back to the sequencing piece.
Y volviendo a la secuencia.
Thank you, Nu. I just wanted to acknowledge that I believe Sandy wasn't simply making a comment. I think she was also asking a question. So I wanted to answer that as best as I can at this time.
Thank you.
Yes, indeed, that planning is underway, and I don't have the details to share at this point in time. And the planning is also taking into account the fact, as you've said, rightfully so, that it's not a monolithic group from a variety of perspectives, and also working around what the equity-related strategies need to be within that group as well. So, Sandy, I'm more than happy as we get more information to share that with you offline if you'd like.
Thank you.
Mm-hmm.
Ruth, I also see you, Ruth. Maria?
Yes, I just wanted to highlight, it really helped
Oh,
me a
I'm
lot.
sorry, Ruth. I had Maria going next, and I
Sorry.
I see you. I see your hand raised. So my apologies for. I'm going to go with Maria, Xenia, and then Ruth, and then we are definitely going to pause and go back to this piece, please.
Thank you.
Maria.
Thank you. I agree with everybody. I think that trying to fit. I like what we have, but if we're gonna be challenged, I think we need to figure out how to get the people that are most affected and the people that historically have always had racism as part of their work, and that we need to figure out, could we explain this better so that people understand, and the numbers show it. So could we use our data and say, this is what we're seeing, this is what we're recommending, and so that we don't have to, if we don't have to mention BIPOC, then let's not mention it, but mention the reasons why we're choosing this, because I think that this can help a lot of our people and we can get it through. Historically, we have lost a lot of people, and we still are losing people, and so we need to figure out how to get, and I know operationally it's going to be hard, because even at our site, operationally, to just do what the governor is saying right now, it's one of the hardest challenges the organization has faced. So doing this is going to be harder, but I think that it needs to be done. Thank you.
Thank you so much, Maria. I think there was an agreement with you in the chat regarding just trying to get a definition that we could move forward with as well. Zhenya and then Ruth.
I'll just read my comment. In the interest of moving us to the discussion of prioritization, I think I see our group as needing to make a pretty crisp decision right up front. And that is, do we make a recommendation to include this entire list as the next priority, and then let localities decide based on their unique needs and specific outreach efforts to certain groups? Or does our group choose to call out the next priority subgroup? For example, under 65 with specific health conditions. And we, once again, then the outreach takes care of making sure that these underprivileged areas get addressed. So I think that's our fork on the road. Can we say the entire thing and let counties decide, or do we literally need to start calling one by one right now, in which order they go?
Thank you for that, Zhenya. I'm going to ask that Ruth go next, and then we will take a 5-minute pause right after Ruth talks, and then we will start looking at sequencing these pieces. Ruth.
Thank you. I just wanted to, it helped my thinking a lot just to read a statement that was in one of the attachments that came to us as part of the packet, and that was from the BIPOC Legislative Caucus. And I'm just going to read the language because I think it's helpful thinking about this. The groups that are in there, they speak to, and they said, however, these frontline and essential workers, adults in custody, people in low-income senior housing, and other congregate care settings are disproportionately BIPOC, and by prioritizing these groups, we are centering on BIPOC communities.
Thank you, Ruth. With that, I'd like to ask that we take a quick 5-minute break and then resume in 5 minutes. Thank you, everyone. Okay, everyone, welcome back. I have 11:05 on my clock and we're going to power through this. I want to thank everyone for their conversation for the first hour already. It's been very robust. I do want to first off acknowledge that I would like to start the conversation during this next piece with the priority population. Kristen, in our last chat piece, made the recommendation that we have a definition working with, my apologies, Kristen, I want to get it exactly how you said it. So I'm going to go back to what you had put. The recommendation would be for us to use to include a statement. My apologies, my chat function just keeps. Is somebody able, Kristen, could you read your, thank you, I apologize.
That's okay. So my recommendation for us, we keep talking about the conversation of whether we can include BIPOC or not. And I think what I'm hearing is that it really just can't be I'm going to stop there. My recommendation is that we would include a statement along with our sequencing recommendation, something to the effect of that our sequencing was in consideration and in review of the data and needs of the BIPOC community. So I think that we can still do both. I think we can still sequence with those other needs that we've already addressed and also include an intentional statement around the data that we reviewed and considered to make our sequencing.
Yes, thank you, Kristen, for making that motion to do that. Before I take some more questions and comments, I know that Dr. Duldalau and then Sean will be next. Dr. Duldalau, then Sean. Do folks feel like at this point in the conversation, this motion to make the recommendation to include a statement along with our sequencing, something to the effect that our sequencing was in consideration and in review of the data that and needs of the BIPOC population. So what I understand is that that would be the way to address, not address the priority population BIPOC that we have listed here. Yes, please, Leanne.
Leanne, sorry, I can't find my hand raise function on this.
That's okay.
Can I add to that I believe that Dr. Gonzalez had also some additional considerations as well related to the data. While we're using the data we have, that data is not always representative from an equity perspective, and that racism in the system, public health and medical system, and lack of access also factor in. So if we're thinking about some sort of a philosophical statement, and I'm just paraphrasing what Dr. Gonzalez said much more eloquently, but I would also please not overlook that piece of it as well. I shouldn't say it that way. I'm not implying to overlooked it, but remember that piece of it, please.
Yes, thank you for that, Leanne. And definitely we'll want to, there'll definitely be some fine tuning of that statement. Yes, because I know that some folks had also said, I believe Dr. Duldalau had also made mention of including structural racism as well. So I'm going to have Dr. Duldalau, Sean, and then Dr. Gonzalez, and then let's, if you folks don't mind unmuting and making your statement or question.
Thank you, Nu. So just for the record, I do agree with Kristen in having some sort of statement. I want to mention that I know that Ruth, you brought up the letter from the Legislative Caucus. Disproportionality of BIPOC in those groups is not the same thing as those groups being predominantly BIPOC. So if you still target those groups, you will still get majority of people targeted who are not BIPOC. And so I think that that is a really fine distinction, but it's a really important distinction that when we talk about disproportionality of these groups and we're not identifying explicitly BIPOC, you are not centering, you think you're centering BIPOC people, but you're not because of the makeup of the state. The other thing I want to mention, I'm not saying that I don't think we should use a proxy for BIPOC, but something to keep in mind is that poverty and SES does not fully capture the impact of racism on the health of BIPOC people. This is well-founded, backed in the public health literature. And I work in maternal child health, And it's a very common finding in our field that African American women who have college degrees or higher graduate degrees have worse birth outcomes than white women with a high school degree. And so SES, education poverty, does not account for all of the impact of racism on health. That's it. Thank you.
Thank you. Thank you. Sean, go ahead.
Yes, I agree with the comments so far. I think it would be helpful if we know we're going to do the paragraph that you've started talking up at the top. If we're not going to call out and use a proxy instead, if we could delete the first box there on BIPOC so that we know what we're looking at as the actual list. And then I also wanted to ask whether we were going to include some kind of a box in here on local public health departments being expressly charged with identifying particularly vulnerable populations in their county to address, something somewhat generic, but with that to emphasize something about specific vulnerable populations that local public health departments would identify.
Thank you, Sean. I want to recognize that I do see some hands raised, and for the sake of moving forward, I would also like to pause for a second and address this piece. Do folks in the VAC feel comfortable? This is where we might need to, at least for the sake of moving forward, do a quick sense of, do folks feel like comfortable enough? We don't necessarily have to love it, right? So it's about, sounds good, I'm okay with it, I'd like to move forward. Or I have reservations would be a 2, right? So sequencing was in consideration and review of the data and needs of the BIPOC community. And we will have better language around this. And then the piece that Sean just suggested was local public health authorities being charged with engaging and serving vulnerable populations. I'm not sure if that's part of the statement or if that's a value or part of the recommendation, Sean. So we'll leave it there for now, if that's okay. Could
I ask a clarifying question, please?
Yes.
First of all, I absolutely agree with Sean about the local public agencies. When we talk about BIPOC, are we then excluding other refugee populations that maybe wouldn't fit under that definition that are also adversely impacted? I just want to get clarification on that. I've been struck by Zhenya and her comments throughout this effort.
Thank you, Sandy. And I see that the focus on refugees is also a part of that here. We did move that there last week, I believe. So if you see in that first box, focus on refugees. So that would also capture, I would believe, our Slavic community within the state, that our refugees are immigrants, right?
And some of this, as I'm writing, I do welcome people specifically giving me instructions on what to write. I don't want me missing or mischaracterizing anything. So if you'd like to be specific on your requests, I welcome that. And verbally, because I can't see the chat right now.
Yes. Yes, thank you, Jamila. Please help us with fine tuning the definition, and we know we can still work on this as well. I also want to give Rachel an opportunity to, did you have a specific piece that you wanted to add or point out, Rachel? I see something in the chat, and I see a lot of agreement with what you had to say. So I wanted to, did you have some clarifying words for this group here?
I just wanted to, thank you, go back. I didn't mean to take up space, but I will since you're calling me new. This committee has talked a lot about the data on health inequities. And I think that, some of the last comments around different communities are disproportionately impacted by health inequities not by virtue of their race alone, but by virtue of all of these other things. So that's another way to talk about it, rather than parsing refugee versus BIPOC versus its race, is those who have COVID health inequities or inequities in underlying health conditions that would put them at an increased risk for more severe outcomes from COVID.
Okay, thank you for that. I see you folks that have your hand raised. I will call on you in just a second. I do want to ask that we agree, at least for this piece, to move forward. So can we do a quick hand vote, and you can put it in the chat. It would be 5, I love it, 4 sounds good. And this is just for the piece about incorporating BIPOC as part of our statement of intention, right? So it would be 5, love it, 4 sounds good, 3, I guess I'm okay with it, but I will move forward. 2, anything 2, 1, or 0, we'll need to readdress it, because with consensus process, we do want to make sure that folks are in agreement to move forward in this way. So anything less than a 2, I would ask that you folks also, I will call you to state your case or ask for more clarifying questions to get you to that place of a 3, if that makes sense. So if OHA staff can help me look at the chat and identify whether folks can feel comfortable moving forward, I would appreciate that. And please, everyone, please do put this in so we can take a look at this.
Maria said 2, just clarifying.
Yes, I just want to.
Please.
Are we removing the sequence of BIPOC as first? Because that's what I heard, and then it didn't happen, and so or are we just adding explanation?
It would be removing BIPOC as a group by itself, but acknowledging in the statement that to address health inequities, that is the focus by which we would be doing by addressing.
But then like all like say we'll start with adults 16 to 64 for people to identify, to look at their to look at them that way, to find those people in that group. Is that what we're saying?
We haven't got quite there yet, Maria. We're really just trying to address the piece of how we want to further the intention of the group with regards to BIPOC as a population group as a whole. So we will address them. However,
Yeah, I don't know. I'm a little uncomfortable but I guess we could move to the 16 to 64 and make sure that this group is going to be identified by whomever is doing the work, and that's what we want. Because is that what we're saying? That this is going to be done, and the people in the 1664 are going to do their best to identify the groups that are in the BIPOC communities and others. I need to see that somewhere.
Okay. Thank you for that, Maria. I'm going to pause for a second. I'm going to go to the folks who have been patiently raising their hands. I'll go with, who did I leave off with? I'm going to go with Marin, Muse, and then Charity.
I've also.
Dr. Gonzalez, my apologies. You also. So I'll go, and you were, yes. Dr. Gonzalez, Marin, Muse, and Charity, please.
Thank you. I would just like to, I thank you, Maria. I think we're talking about communication and framing of accountability. To Sean's point, I would recommend that we do not remove the evidence of BIPOC in this top row of our sequencing plan, but somehow maintain it there so it's not erased. Perhaps it's not how we orient our prioritization around BIPOC, but I would like to maintain it in some way so that it shows this is where we started, that we have a deep commitment to centering and revealing the ways in which structural racism impacts the disproportionate rates and cases and exposure to COVID in our communities of color and refugee communities. In terms of the statement of intention, we started here in acknowledging structural racism and its influence on COVID to BIPOC communities and refugee communities. We faced pressure from the systems that are not prepared to center this kind of justice. So our reframing is because of that as well. Our system is not yet prepared to center on and reveal the truth of structural racism and how it plays out. And that I want to say these things so that we are mindful as we move forward in all the other decisions that are going to be made. History does not show that we are well prepared to reveal the ways in which structural racism impact our communities historically and contemporarily wise in today.
Kelly, if we leave that as still the top piece there, could you, I know that you had put in a 2, meaning you had reservations. Do you feel like you could move forward with this piece here? If we continue to have it maintained as BIPOC in a row, in that row, without sequencing it, do you feel you could move forward? I apologize to put you on the spot, but I want to also recognize that for those of us that had voted 2, we need to kind of move towards a place where we feel we can do this in agreement.
Yes, I can. And the reason to do this is to keep us accountable.
Absolutely.
To move forward to address the reasons why we're not able to center on BIPOC in our future decision making.
Okay, thank you.
Is there specific verbiage? I put the acknowledging structural racism in kind of as a placeholder. Is there specific language folks would like me to write on this document?
I also, Jamila, sorry, it's also the pressure from the systems that are not yet ready to address and center this truth and reconcile the ways in which structural racism impacts our health, the disparities that we experience.
Thank you, Kelly. I'm going to go to Marin, Muse, and Charity, and I know many of you have raised your hands as well. And so, Marin, please.
Thank you. And I agree with Kelly. And it's unfortunate we have to play these games because of the legal issues. But I think maybe another word, vulnerable or disadvantaged populations would tend to be BIPOC communities, mostly when it comes to dealing with health, economic, or educational issues. So I don't know if the word vulnerable and disadvantaged in terms of from a legal issue, we can capture that. But I do agree back with Kelly's comment about that. It's unfortunate that we can't be intentional because we know people will be falling through the cracks. It has happened for the last 200 years. It'll continue. So, but again, moving forward in terms of a practical standpoint, I know we have really little time. Maybe the wording, in terms of vulnerable or disadvantaged populations can be used in a way that is focused on these communities somewhere throughout the language.
Thank you. Muse.
Thank you. I just wanted to, BIPOC, I'm okay with the word BIPOC, but that doesn't define all the other problems that this community has facing with it. So my also other concern is serious concerns that I have is the local system that have actually created this problem that doesn't know how to address it, doesn't know how to deal with, to be handed over to. I think I see as a waste of our time and energy. That need to be a word language in there. Should be also some form of oversight on implementation of our whatever advisory group that we send out to them. Another word I always want to caution repeatedly is the census should not be used. This is somebody who lived here for 40 years to have experience with this community, specifically the African community. The census is not a representation because majority of them moved within the last 10 years. And the last census due to COVID and also not funding the CBOs that actually serve this community that means the numbers do not translate. So my biggest concern is more than anything else is to keep the word out there. Also put a word as far as the zip codes, something that kind of specific to neighborhood where this population lives as a way to kind of also put in the language. But more importantly, I want to make sure that the handover, whoever's going to implement our recommendations should be strong and should not be left to the local government. Thank you very much.
Thank you, Ms. A. And thank you, Ms. A. Charity.
New, before we jump on,
yes,
I guess I look to you as the facilitator to instruct me on how to edit.
Thank you. I would say that what you have right now, again, this would be draft in a lot of ways. So I appreciate you trying to capture as much of the intent and essence of the conversation and the intention of the words that folks have provided. I would say that I'm asking that the VAC would also jump in to help edit this. We will have opportunity, I believe, to look at this again after today and really make sure that we get the wording to the degree that folks feel comfortable that they can move forward. Does that help? Does that help, Jamila?
It does. I'm trying to, yeah.
I understand you're doing a phenomenal job trying to capture this. And so I would say, I think we're good with the statement of intent at this time. What I want to do is get in a couple more folks who've been patiently waiting to ask their questions. And then I would like for us to look at throwing ideas out for actual grouping of the folks here. So I'm going to go with Charity, and then I would like to pause for a second and move forward. Charity, please.
Thank you. Sorry, I feel like maybe I misunderstood. I thought we were voting on the statement of intention and whether to keep BIPOC in there or not in that statement. Can you clarify, is that what we voted on? Because I feel like then it got stated that we were voting to remove BIPOC as a priority group, and I am not sure that I don't think I agree with that. So can we be very clear in what it is we're voting on moving forward?
Yes.
Yes. I feel like it's moving so fast and all over the place. And
yes,
I said a 4, but I do not agree with removing the BIPOC. So I would have changed my vote. And I apologize if it's just me who misunderstood.
No, I would imagine it's not just you. Thank you. Right now, what is on the floor for the VAC is we have put forward the statement of intention. I'm just going to read it. Acknowledging structural racism and pressure from systems that are not ready to center this truth about the ways structural racism impacts the health of Black, Indigenous, and people of color communities. Sequencing was in consideration and review of the data and needs of BIPOC and focus on refugee community. That's the intent. What was put forward when for the vote was including that statement of intention. Folks feel that with that statement of intention, we could move forward. We're leaving BIPOC, that priority population there. We are not necessarily, my understanding is that we're not necessarily moving the priority population. We're not going to sequence that specific population as a group. Is that correct? Is that folks' understanding? Yet we're going to leave it there, knowing that we do not want to, we are not taking that off as a priority.
Yeah.
Does that sound like what folks were voting on? Please correct me, please.
Yes. I
Yes.
just,
Sean,
I'm just happy we voted on something because
yeah, I think it's there.
We're always going to disagree. We all have our cultures. I've said very little about Black people. The Black people that are in this group, we've said very little. Other people have spoken for us who are not Black people, but we haven't said anything because my goal is just for us to put something in agreement on. The little things that are important we can work on, but we're on meeting 4 and we're having we always wait till the really last minute to agree on something. And I'm feeling really frustrated with that. Let's just agree that everybody's needs for our community and our people are not going to be met. But I would just love if we could just focus and agree on an agreement of some kind.
Thank you, Christine. I'm going to, one, apologize for jumping out of order, but I do want to hear from Nanette. We haven't heard from Nanette as often, so I would like to offer, Nanette, you have your hand raised, the opportunity to share, please.
Hi, New. I am a little bit perplexed in that I'm confused as to the sequencing having to be one or the other instead of, I was under the impression we were identifying the group, and then as the vaccines become available and the individuals show up for their appointments, that they can receive it because they're in this 1B group. So then if we're paring it down further, then we're going to keep running into conflict as to who's on base 1, who's on base 2. So I just need to have an understanding that we're looking at the group as 1B, and then as the individuals come up, we don't want to have vaccine waiting for bodies and they're not there because we've sequenced. We have to have this group first before we can go to the next. We're identifying 1B as a group, or are we not? That's what I'm after.
Nanette, I guess to clarify, that's true. We don't necessarily want to hold back groups if the vaccine supply goes up, but we understand, just given the estimated populations are so large, that it will take a very long time for our vaccine supply to actually catch up to this estimated numbers of people we need to get to. So that's why, in the interest of getting vaccine out available in any kind of streamlined way, as far as demand right now exceeds supply by a lot. So that's why we need to have some sort of ordering so that we know exactly who to start with, just because the groups are so much larger than the vaccine supply. Does that make sense?
I understand that, but we still have the challenge of, we know within our own communities the hesitation and the reluctance, and we still have to work that out. If we are paring down to that minute level, my fear is that we will become ineffective. And what we're seeing is the governor and others are making decisions to move forward to get vaccines into individuals, and then all of our efforts become a moot point. And that's why I'm sticking with the group as opposed to the paring down so much.
I would say, if I could chime in, I think that's a good point. And with this, we know that whatever the sequencing is, that we will do that planning, and that there are certain groups that need that runway. It helps us to know who's next to be able to begin those communications in that runway for those groups that need more information, like many of the people that we're talking about. You all could put this forward as a group, but I also want to be transparent. It's a very large group. So at some point, somebody is going to be needing to make decisions on how to operationalize this. And I think this is your opportunity to tell us, this is how we want you to do it, because the group is so large. And so, you know, in one sense, Nanette, thank you. Yes, this is the group. This is the 1B. And I think that we can talk about it like that. But any guidance you can give in terms of how to move forward if we don't have enough vaccine is going to be immensely helpful to us.
Thank you.
Excuse me, no, I'm just wondering. I mean, we know that people are dying, and we know that there's people that are very sick, and we know that people that are sick are of all races and colors and stuff. So, and we know that frontline workers, I mean, are working and are out there and getting exposed, and our BIPOC people are in all areas. So why can't we work that way? I mean, it looks like frontline workers are you know, our BIPOC people, that we all work in this one. We have sick people everywhere. I mean, I think that if we look at this and say, yes, we have to prioritize when this starts, and we can say we can go in this order. But if an adult, you know, 60-year-old Hispanic goes and is not on the line, will they not get the shot? I mean, or the vaccine? I'm just thinking that all our people are in these areas. I mean, when you look at it, they all fit one of these categories. So why can't we just look at that and say, just assure that that the state assures that they're going to be looking at this and saying, these are the people that need it, and how can we apply that to all the groups below? Because we're not 1664 are not white people. It's everybody. So why can't we do that and just say, apply this with this lens, and this lens means look at what's in your community, look at different ways, zip codes, census, I mean, whatever they want to use, but look at the community and say, you have these people in your area. Let's look at them through this lens.
Thank you, Maria. Marin has his hand raised, and then I believe it's Dr. Rafael and then Dr. Gonzalez.
Thank you. And again, in moving forward, I'd like to propose that, and I agree with Maria that BIPOC encompasses all the different groups that we have here on our list. So moving forward, I would like to recommend that we proceed, you know, if we look at the population, say the populations, people with underlying conditions, frontline workers as the top two in terms of sequencing, for me, will be very important as to a recommendation, and then the rest of the people within the list.
Okay, so I have a motion. What I'm hearing, Marin, is that to move forward, we are going to ask the VAC, do we want to go ahead and put next one, adults 16 to 64 with underlying health conditions next, and then frontline workers as part of the sequencing? Is that what I understand?
Yes.
Are we voting now?
So Dr. Rafael has been trying to add to this motion. Can we hear from him?
Yes, Kalani, please.
Thank you. I'd like to add to this motion that we, one, have a statement of intention and a statement regarding interacting with the local public health authorities that we believe are important but are in draft mode that requires further discussion so that we can move on from that. I would also like to add that one consideration in terms of supply demand is that we could potentially prioritize people within Marin's two groups by age if necessary. And that is a flexible recommendation. And I agree with Marin's points. I would also include people in custody and multi-generational households in those groups, as well as the third group, because I think those two groups are small, the people in custody, and we could vaccinate them rather quickly and eliminate those outbreaks that are occurring in jails and prisons.
Okay, so I have a kind of a combined motion here. One, what I'm hearing from Kalani is that we would include the adults and youth in custody with sorry, where would you combine those, Kalani?
Basically, I'm saying all these 4 groups below BIPOC because unfortunately we cannot prioritize BIPOC. The reason why I like including adults in custody and people in low income housing is that's roughly 26,000 people. And that could, you know, essentially wipe out possibly, you know, the outbreaks that are occurring there. You know, it's obviously much greater numbers for the adults with underlying conditions and frontline workers. And if we need to prioritize within those groups, we could come up with an age-based system to deal with that.
Daisy, you have your hand raised.
Thank you. Yeah, I definitely agree with what you all are saying. I think, I don't know if this would go in part of the statement of intention, but I think it's very important for us to also recommend that whoever is doing the distribution work with CBOs and trusted identities with the communities that are working directly with our BIPOC and refugee communities, because that's going to be very essential to be able to get that vaccine to the right people, right? And also do that education. We really need to make sure that we are going where we trust and that we are not going, right? Probably not going to go to the Salem, to the fairgrounds where there is National Guard and folks who can intimidate our community. So I really would like to add that somewhere, whether that's in the intention or just as a recommendation, to ensure that we're working very closely with CBOs and trusted identities that where folks feel comfortable going.
Thank you. I'm going to go to Kelly, Safina, and Muriel, please.
Thank you. I would like to add that we also create and use data along the way to evaluate how this is unfolding, and so that we can capture some of the issues that are being raised around medical mistrust and barriers that may make it more difficult for populations to access the vaccination, depending on how that distribution and the planning looks.
Thank you. Safina, and then Muriel.
So what I wanted to say is kind of in alignment with what I said in the beginning, and it's in alignment with that local public health statement. And I put the wording that I think something like that should be there. And it's consistent with what Daisy just said, but local public healths are charged with engaging and serving vulnerable populations. And I really think it needs to be in a directive and a charge so that people know that it's not optional, that it is supposed to be locally driven and community driven. This includes partnering with community-based organizations, FQHCs, and other local organizations to develop a community-informed, equity-informed local vaccine distribution plan. I also think it's really important to highlight that the fact that this might take months. So that the intention isn't that in 2 weeks, all of these people are going to be vaccinated because of supply, but also because of potentially vaccine hesitancy and needing to build community trust or whatever the reason might be. It might take months for this to be completed, and that's the reality.
All right, thank you, Safina. I'm going to go with Muriel, and then I'm going to take a pause to regroup us on this piece. Muriel.
So from a local public health authority, I think part of it is we know that working with vulnerable populations is part of what we do. It's what we do every day. And, working with our CBOs, this has been new, but it's been a great, we've worked with CBOs before, but more of an intense with wraparound services has been a really great opportunity for us to open that up and really create that opportunity to kind of reach out to those populations that we may have had some challenges. I think we really try to hire staff that represent those communities. And I'm only talking about one health department, but I'm not just talking about one health department. So I think part of it is we know this is important. Many of my colleagues
have been reaching out to various populations in their counties. And I think the other thing too, I have seen some of the issues in relationship to really large clinics. There is some pushback to that. And I think many of us are trying to give people options. So they can go to a large clinic, we can do an appointment at the office, we can do a smaller clinic or go to locations. So I think from the local level, we're really trying to do all of those things to make sure we're reaching out to people. So, and I know for myself, and I know many of my colleagues, that's the way we've been working on this all along, whether it be education and information. But we are happy to take on that charge and to do it, and know that we're already working on that.
And thanks, Muriel. That I did use the word directive, and I didn't mean it that way. What I meant was kind of what you're saying is that with the local public health departments that we work closely for, they've asked to be able to do it because they're already doing it. And so if we say that it's a charge, it gives them the authority and the empowerment to do what they're already doing. And thank you for changing that articulation.
Yeah, I think that's important because we are doing a lot of that work now. So it just, but I do think it's good to have that language in there, knowing that that sort of brings it to the forefront.
Okay, thank you, everyone. I'm going to,
just one more thing. Can we add, because federal qualified health centers are seeing all this population. We see people from all over, 62 different languages, and so do other FQHCs. So could we also figure out a way that the local health department works with the FQHCs, or I know FQHCs was part of the list, the distribution, but I wonder if that could be added in there somehow. Because federal qualified health centers, some of them are getting the vaccines and some of them are not. But they have the people and they know their work. So I'm just wondering if that can be added somewhere.
It's in the statement that I wrote in the chat. And so if
I believe it's being captured there as well too. Jamila just included it, so thank you. Okay, in our last final push here, I'm going to ask that we kind of stop on comments for a second, and I'm going to move us to a place where we look at the sequencing. Again, refocusing our minds and intentions on the fact that this group, the VAC, was charged with looking at sequencing. We know that implementation and distribution is part of that, and yet we are not discussing that right now, right today. Today's decision is about sequencing. So I want to again refocus our focus on that. Can we scroll up a little bit on your document, Jamila? Thank you for capturing all of that. We will also revisit kind of the wording about statement and intention. So if the pieces that people, VAC members move forward on accepting the motion of, I want to go back to, can you scroll down a little bit to
the second page?
Yeah, the second page. So we have, right now, we have listed adults 16 to 64 with underlying health conditions. So that would be one group. Frontline workers, adults and youth in custody. There was a motion to move that particular group along with people in low income and congregate senior housing up. Is that my understanding? Is there also the option to kind of within the last, 5 groups, to create 3 groups perhaps in that? Clumping, I don't want to say clumping, moving them together as a group, like the smaller potentially estimated population size by adults and youth in custody, and then congregate seniors in congregate living as a group?
Yes. I might not be understanding. So on the left-hand side, we have the sequence box.
Mm-hmm.
Are any of these not number 1? Are any of these not being prioritized?
Hi, New, it's Moran.
Yes.
I think what myself and Dr. Kalani said is basically that we have when I said two groups, I meant adults with underlying conditions and then frontline workers. And then Dr. Kalani said, let's include the other three categories within the
that group.
underlying conditions, I believe, or somewhere in there. Is that correct, Dr. Kalani?
Yes.
Yes. I think that was a motion.
Okay, that motion. Let's move on that motion. Do folks, so I want to be able to see it.
Can we go down?
Can we scroll down? Yeah. So that motion, Marin and Kalani, if you can help fine tune so everyone understands. Are we moving the motion for adults, youth in custody, and people living in low income as part of
adults 16 and 64?
Is that what we're doing? We're actually putting more people in that particular group, or is that just moving them, bumping them up, assuming that we are starting with adults in 16 to 64 with underlying conditions as the starting point?
I heard it as including them in 1B and calling them out as part of 1B. Is that correct?
Well, 1B includes
All of
individuals
them.
older than
All
65.
of them. Yeah.
So this would probably end up being 1C. So it would be the 5 groups you see here is what I'm thinking. And I argue that the reason to include adults and youths in custody and people living in low income and congregate senior housing is that it's a relatively small number of people that can hopefully wipe out the outbreaks that are occurring there.
Kalani, would you call them out separately?
In terms of
instead of grouping them in with another group?
With 1C, like making them 1D?
No, I think it'd be like making them 2, right? So starting with 1, then 2, then 3, group 1, group 2, group 3. Is that what you're thinking, Sandy?
No, what I had heard is that we want to name these, right? And I thought you were suggesting we create one group that puts them all together. No,
I wasn't thinking that.
Okay, well, yeah, I was hearing that from New. I think we should name them.
Yeah.
Can I ask a clarifying question on the underlying health conditions? Because that 735,000 population is the broadest definition, but I believe we came up with a more refined list at our last meeting. And are we talking about the more refined list or the CDC list?
We haven't voted on that yet. New, do you feel like we want to get to the numbers for these groups first and then decide on that?
What I would say, if I could offer, is a couple things that are meant in the spirit of moving us forward, and definitely not to do the opposite of that. I think that we can spend some time operationally defining what's in those with underlying health conditions. I know that you all's intent has been to be broader than what the CDC is. I would say I would guide us away from the CD and E language, just because that's going to get really confusing with what the CDC and other folks call. And so just to do a check, what I thought I heard is that from the multiple proposals that adults with this one, you start here, 16 to 64 with underlying health conditions, and also at the same time have adults, youth in custody, and multi-generational households, because it's a relatively small number, and then move on to frontline workers. Is that a fair summary?
I was thinking all 5.
Oh, at the same time. So 735 plus 483,000 plus 26,000.
Well, there's going to be a lot of overlap, right?
Yeah.
I mean, it's a huge group. This is the challenge though, right? It's so hard to do this. And I think that's sort of where the flexibility with the local public health authorities comes in, and the language about, being flexible can be helpful.
Well, and I think that's why we had a lot of discussion last time around whether that 735 is really the number with underlying health conditions, because we identified very specific ones. And then we also talked about, like Washington State does, where you have 2 or more comorbidities. So it has a impact on the ability to really implement in terms of what we're doing with that.
I want to ask Leslie to jump in. You've been patiently with your hand raised.
Thanks, New. My comment was maybe not relevant now, but I was looking at the motion language around providing age flexibility in each one of these categories. I think in the chronic conditions that would not necessarily produce an equitable circumstance. There are some conditions on that list, for example, cystic fibrosis, that they're so serious, you don't see people in older age groups having that condition. So I would suggest we don't age stratify the chronic condition piece, just because I think it would produce inequitable outcomes based on diagnosis, just because of the severity of different illnesses and how they impact youth versus older adults. Thanks.
In the interest of time, I know there's a lot of motions right now to move forward. Rachel, is there any flex? I know that we have to get something to the governor's office and OHA by January 31st was our deadline for this group. Is there any possibility that we can either do an emergency meeting? And I cautiously ask that, knowing that folks have dedicated a lot of time to this process, and I don't want to continually ask for more time. However, just knowing that we've kind of reached this critical point of decision making with only a few more minutes left, is there a possibility to move something forward here today and then revisit it on Tuesday or next week, Thursday?
I can't commit at this point. I know that there's been an expectation that the recommendations come in by the 31st, so I can't commit to going into next week. I could say if folks wanted to try to squeeze something in today or tomorrow, that we could try to do that. But I would need to have other conversations before.
Do folks feel like I apologize for this. Do folks feel like they could commit to another 15 minutes so we can kind of get to a place where we move a motion forward as far as recommendations and the fine tuning of vaccine distribution, implementation, and the intention can be worked on in a subcommittee potentially? Do folks feel that that is reasonable? Another 15 minutes?
If we can skip all the commenting and hand raising and just focus on making a decision, I think we can do it in less than 15 minutes. But you're our facilitator.
I have a couple hard stops at 12:05. So Marin, you had a comment?
Yeah, so I guess, simply put, like Christine said, right now we have a motion.
Yes.
And I think all the other details we can discuss at a Tuesday meeting when it comes to implementation and further definition. But I think right now, if we stick to this motion, I think we can get it passed.
Okay.
Yes.
Okay. So let's.
I'm sorry, I'm still not clear on what the motion is based on. It sounds like we haven't prioritized anything. It sounds like I'm not understanding based on the numbering system and then based on the language.
Can we go down to the second page and put some numbers? Have we proposed? The motion was to put adults 16 to 64 with chronic conditions, frontline workers working on site, as well as adults and youth in custody, as well as people living in low income and congregate senior housing, all as one. They would all be one, with the understanding that significant overlap. So it might not actually be 1 million people like it looks tabulated on the screen.
And some discretion with local authorities to implement it according to what they need in the locality.
Yes, that's captured in intent above, yes.
So this would be just to agree that these groups can all go together as first group of 1C, let's call it.
Does that include the multi-generational households?
Multi-generational households would not be included. They would be number 2 per this numbering system.
Can we have the numbers in the box?
Yeah, can we put the numbers in? It's a little easier if you see a lot of 1s and only 1, 2, and for people to kind of. So that would basically mean 5 of these groups would be 1, and then multi-generational households would go after them, and preceding the rest of the general population not captured in any of these groups.
So can we call the question about the motion?
Is 1B, and that you're saying the rest of these are 1C?
Yeah, because we already have a lot of groups in 1B. I think Kalani had proposed calling all of these 1C, and these are groups within 1C.
Correct.
Because the governor has already put quite a few people in the 1B category, again, just thinking about movement of a whole group of folks, right? So this would be the 1C, just
I would actually
for the
caution
sake.
us just between going down the C and D route and
Okay.
just kind of going in order, just because there's numbering on the federal level that I just think will be very confusing for the public.
Okay.
So I would say we know who's going next, and educators and those 65. Who is this group saying is going next? And then who's going after that? And then the general population.
Great, thank you, Rachel. Does that help clarify? So this would be a motion to move all those that have been marked as 1 forward as the next group of folks in line. And then it would be number 2 and then number 3. Do folks understand where we're at with the motion?
Yes.
Okay.
Does the motion include age stratifying though? I understand where we are on this, but I need to
No.
talk about the age.
No
Okay.
age stratifying.
Thank you.
Okay, so if we can do the fist to 5, 5, love it. 4 sounds good. 3, I guess I'm okay with it. 2, I have reservations, but I can be convinced. 1, hold on, we need to talk about this more. So anything less than a 3 would not be considered consensus. Deborah, I see you have, do you want to have some questions or comments? I see you're at a 2, so we want to make space and room for you to comment. Okay, I'm looking through the chat real quickly. Has everybody gotten a chance to make their comments about this? And if OHA staff can help me look real quickly to see if there's any other 2s that we need to give people opportunity to ask questions or.
Yeah, Lori
Yes.
had a 2.
Thank you, Kristen.
And Deborah too.
And I know Lori had to, is Lori still on the line?
Yes.
Please, Lori, I know you have to go.
Yeah, my main concern is just that I don't feel like this gets us to where we need to be. One of our earlier meetings, we sort of identified these groups and we haven't made any progress. And, whether it's 500,000 or 1 million people, they're not going to be vaccinated in a week. And so I just don't see that this moves us forward in terms of sequencing. It's not specific enough. That's my issue. I don't disagree with these groups being prioritized, but I don't see how that the public is going to accept 500,000 people, as the priority.
Yes.
Yeah, I think Lori's right, because even within adults over 65, the way the governor has tiered it is by age, and that's the only way they were able to make that more specific. So yeah, so that is still a gap.
So with the,
I think
with
we
that,
could
go ahead.
maybe say somewhere that, these could potentially be revisited depending on supply of vaccine. It's just so hard, very, very challenging.
I have a hard time with us making, sorry.
Go ahead.
I have a hard time with us making decisions, using the numbers specifically as our guideline for the population count, because we don't know at any given time when more vaccines are going to be available and when, if Johnson & Johnson gets approved here soon. I mean, everything could be a game changer at any minute. And so I think I would caution us to get overly concerned with the number of population and just try to prioritize the best as possible. And what will be based on a result of availability of the vaccine.
I think that's a good point.
Yeah, that was what I was going to say. And I also think that you leave it open because we already put in there that local public health authorities are going to be surveying their communities to see among this group where they want to target that distribution.
And making sure to say that this is going to take time. The intention is not that all these groups get vaccinated within a couple weeks. The intention is that they get vaccinated before the general public, and it could be months.
Yes.
Yes, I agree with that.
Yes.
Can we get Deborah's point? I don't think she had a chance to talk as to what her 2 was about.
Deborah mentioned that she's made her points as well. And
Oh,
so
she
Deborah,
did.
we do want to open that up to you. If you want to continue to add, we want to make sure we recognize where you're at with that.
I'm trying to understand this a little bit better, and I understand the national sequencing. So I know that we've left out age and we're looking at more at populations. So, and I understand the legalities of having to leave out the BIPOC terminology, but I do like how you have addressed it in the wording above. So I did talk with, I think, Cara Biddleton last night. She called me and we talked about this, and she talked about the legalities of the BIPOC language. And so I've been trying to wrap my head around this. I'm not a medical professional, but I do understand that we're trying to prioritize these populations, these specific populations, and how my demographic fits into this. So I also like that you have left it to the local COBs to determine the most need, because I think that's how the native population that I'm concerned about will get vaccinated that way. So I'm willing to go ahead with this. I was hoping that multi-generationals could be in the category 1, because the population that I am advocating for, most of them are homeless. I don't say anything about homeless, so that does put them at a big disadvantage to get it. So I'm willing to vote for this. I know that there are a lot of systemic problems in the processes that would take much longer than we have here to address those things. And I was trying to go back and reflect on the governor's directive to this committee. So, for the sake of moving forward and getting the priority, I would have to say I would still be a 2 with reservations, and this is going to be an ongoing process, I believe, to make changes. So those are just my comments right there.
I knew I'd like to talk about, I do feel that homeless is really important, but I'm assuming most homeless people have chronic conditions. So my thinking is that if we meet next Tuesday on the implementation, we talk about strategies as to how to target certain groups within these groups when it comes to outreach, education, implementation, because that's going to be critical. But I do agree that most homeless have chronic conditions, health conditions, mental or physical, so they can cover into that area.
Yeah, we definitely need to talk more about implementation and strategies and whatnot. What I'm hearing now is that we've heard from folks who still had the reservations but feel like they can move forward. I know that Lori had to leave, but also stated in the chat that she could also move forward with this with reservation. So what I'm hearing from the group is that we're landing here as adults 16 to 64 with underlying conditions, frontline workers yet to be defined, adults and youth in custody 16 years and older, people in low income and congregate senior housing. That 4 would move to the next group, and then 2 and 3 would be following them.
Not to add a wrinkle, but I heard from Deborah that multi-generational households she would like to elevate. I would be in favor of that if folks want to consider that. This is Kalani Raphael, by the way.
Thank you, Kalani.
Not to be a stickler about numbers of vaccine, but that would kind of elevate the group. Would folks want to replace multi-generational for one of the other groups labeled 1 currently, so that it goes slightly above or after?
I think we need to proceed as is.
I'm sorry.
I hear that there's a comment to proceed as is. Also, again, remembering that several statements that were saying this is going to take a while to even get to this point of because of vaccine scarcity. So thinking about, with the group moving forward with what this recommendation is, do we feel like we've met the charge that was put before the VAC? I see a yes from Marin. I see both Sean and Nanette have your hands raised. Nanette, I'm going to ask you to make a quick comment, and then Sean a quick comment, and then we'll wrap up. Nanette?
It's really a question. With the recommendation as identified, we are not handicapping any of the administration of the vaccine if the availability is there to cover the whole group at any opportunity of administering the vaccine. This is 1B, and we've stratified it 1 through 3.
Yes.
So anyone can choose if they have the availability to administer it within their particular counties. They can roll out and continue.
Yes.
Not every county is on the same sequence. That's what I want to make sure. So if they've completed their 1s in their county, they can move on to 2, and so forth and so forth. Is that correct?
Yes, I believe that is correct.
No, and I'm happy to kind of wrap us up at the end. I think there's some nuances in that question that I don't want to hear. I want to make sure we fully understand before we're making commitments around that.
Okay. Marin, you had a comment, and then I'm going to ask that we wrap up.
No, I think Sean did.
Oh, Sean, excuse me.
It's okay. Go ahead.
No, I mean, just a simple comment that, we know it's not going to be perfect. I mean, I believe I want perfection, but we know that, but I think the implementation strategies, we can talk about that on Tuesday, that'll make a big difference in how we do this. I really do believe that. And I think people have been talking about CBOs, local public health, other organizations, those are critical to really getting the job done. And through that process, we make sure that the gaps are not as big as they should be when it comes to targeting BIPOC communities, other vulnerable populations. So I think implementation can be very critical for our discussion on Tuesday. So I want to make sure that we discuss that on Tuesday.
Can I also add, please? I'm jumping in. I'm really sitting with what Deborah is sharing as well and feeling grief. I think it's important that we also acknowledge in some way as we move forward the populations that are not included in our sequencing plan, whether it's because they're not captured in the data or there are inequities within the data or other conditions because of colonialism and racism. I think it's important that we acknowledge that.
Thank you, Kelly. As far as Tuesday, that is an optional meeting that we can provide for this group if so desired. As far as the charge, we have completed this process with this particular recommendation. We will get this in, we will get this out to the VAC so that you have it as well. On Tuesday, should folks, this is an optional meeting on Tuesday. I'm kind of trying to figure out, I don't know if it's on your calendars as yet, but we will have an optional meeting on Tuesday for discussion of implementation and distribution. And that's really a continuation of the conversation, not only today, but what was had on Tuesday through the use of what OHA has already been doing within the communities and having your input on that. We will also have a closeout meeting to be determined, and we'll get that information out to you as well. I'm going to turn it over to Rachel for your last comments for this group, and thank you so much.
Sure. Yeah. Thank you, everyone. One thing I want to put a pin in terms of implementation is, and I really hope and I appreciate the optimism of if we get a variety of more vaccines and not limiting ourselves in the current state in terms of vaccine, the amount that we have. I also want to be transparent in saying there will be decisions made if we continue to have 50,000 or 30,000 new first doses a week and an eligibility population that's very, very wide. So I want to be really, really transparent about that in the operationalizing this and implementing that there are decisions that will have to be made. We can talk more about that in implementation, but I wanted to sort of put that out there, and whether it's at the local level or whether it's at OHA level, and probably both, it does necessitate in terms of planning, because ultimately we don't want to frustrate communities by having a lot of people that are ultimately think I'm eligible right now and know that there's not enough slots. So we'll have to think about how to do that in a way that wants to honor the breadth of this recommendation, and also seeks to be working with communities so that they that they're not further frustrated by how to get this in place. So I just wanted to put that out there and say that in that we will continue to be thinking about health inequities. We will continue to be thinking about that and all of the comments that you have said. And I will go back and have conversations about what we can do with next steps as we move forward with planning, and look forward to engaging you all in that planning of how to implement this. Thank you.
Thank you, Rachel. And with that, I want to thank the VAC for being flexible with the additional 15 minutes today. It's a lot of work, a lot of good conversation, and we don't want to cut anybody off short. And so I apologize for those of you who were unable to get in and share what you needed to share. And for all of your work, thank you. We will be in touch. And thank you so much again. So this concludes our meeting today, and thank you for those recommendations that we will put forward to OHA and the governor's office. Thank you, Jamila. Thank you, Shimi.